So let's now proceed to the other causes of megaloblastosis. Now there are other causes of megaloblastosis. Dili lang si vitamin B12 and folate deficiency. So one of those is si pernicious anemia. Now what is pernicious anemia? Pernicious anemia is a type or a form of a megaloblastic anemia, which is due to the fact that there is a lack of intrinsic factor, which then leads to vitamin B12 deficiency. Our body, the stomach natin, our stomach normally produce the factor called the intrinsic factor. Now, intrinsic factor helps in the absorption of vitamin B12. And vitamin B12 is, together with the folate, is used in the synthesis of thymidine, which then helps in the DNA synthesis. So if there is a thymidine deficiency because of vitamin B12 deficiency, there will be an impaired DNA formation. So meron tayong abnormalities na sa mga rapidly dividing cells, especially RBCs. If there is an abnormality in the RBC precursors, and that can lead to premature apoptosis inside the bone marrow. And that will lead to the decrease or reduced number of RBC that is produced in our bone marrow. And that will lead to anemia. Now, short history. Pernicious anemia is first described in the early 1800s and it is poorly understood. So wala pa silang knowledge about the pernicious anemia. That's why they called it pernicious anemia, because the disease is fatal before its cause was discovered. Now in the 1900s, si Whipple and his student William Castle discovered yung protein called the intrinsic factor. So it was Castle who first described the gastric protein intrinsic factor. That's why it's also called the Castle's intrinsic factor. They have discovered that the intrinsic factor is vital to the vitamin B12 absorption. So yun yung na-discovered nila. So demographics of the pernicious anemia, it is most common in the Scandinavian, British, and Irish people, although fewer than 1% of these populations are affected. Caucasians, Greeks, and Italians are affected even less often. And pernicious anemia also occurs in the black people, only 1/3 to 1/2 the rate in the Caucasians. So generally, the onset of pernicious anemia is in the late adult life. So peak age of occurrence is nasa 60 years old. So patients with pernicious anemia often have prematurely gray hair and light blue or gray eyes. So pernicious anemia is somewhat more common in people with blood group A. So ito yung na-discover nila. Now for genetics, congenital PA is rare and it is usually inherited as an autosomal recessive trait. So according to Steniger, the relatives of PA patients are at significantly higher risk of developing PA than the general population. So if you have a relative na merong PA or pernicious anemia, there is a great possibility na yung relatives din nila can have pernicious anemia. So ito yung nakita nila silang study. For PA patients' relatives, one study reported an incidence 20 times greater than that in families where no one has PA. And autoantibodies to gastric parietal cells have been found in a significant number of relatives of pernicious anemia patients when compared to the normal population. So the exact defect inherited in pernicious anemia remains. However, there are possibilities. One, there might be a defect in immunologic tolerance to some stomach, thyroid, skin, and pancreatic antigens. The second possibility is there might be a defect in a metabolic or enzyme system common to these tissues. So, the pathophysiology of pernicious anemia. So, the gastritis associated with PA that suppresses or arrests intrinsic factor secretions and thus produces B12 deficiency may be caused by mucosal damage. There is a mechanical, thermal, or chemical cause, nutritional deficiency, which is related to folate, ascorbate, or iron intake, endocrine disorders, which, so examples kay na siya thyroid disorder, adrenal, or pancreatic disorder. And the next one is genetic disorder or autoimmune mechanism. So, among those causes, yung pinaka-common is the genetic disorder or autoimmune mechanism. So, sa PA, autoimmune disorders have an increased incidence among patients with PA. So, very common yung may autoimmune mechanism. However, the stimulus for the autoimmune changes that lead to PA is still unclear. So, as to how and why nagkaroon ng autoimmune against the parietal cells which produces the intrinsic factor is unknown. So, ito yung pathogenesis ni pernicious anemia. So, we have the stomach. So, our stomach produces, in the fundus region, the fundic region, meron tayong parietal cells. So, ito yung parietal cells. Yung green one. So, parietal cells synthesize the factor called the intrinsic factor and also the hydrogen or hydrochloric acid. Now, in the pernicious anemia, since pernicious anemia is an autoimmune disorder, so we have T cells which attacks the parietal cells, specifically the hydrogen potassium adenosine triphosphate that is embedded on the membrane of the parietal cells. Because of that, there will be a parietal cell injury. So, magkaroon tayo ng injury in the gastric mucosal cells, which will then lead to lack of intrinsic factor secretions and also the other secretory product, which is the hydrochloric acid. So, magkakaroon si patient ng gastric atrophy, which will then lead to reduction of hydrochloric acid secretion, which this condition is called the achlorhydria. So, yan. And because of the gastric injury or gastric mucosal injury na nangyari, it triggers the formation of autoantibodies against the parietal cells. So, meron na tayong naproproduce na autoantibodies against the parietal cells. And that will lead to destruction of the parietal cells. So, there are types of autoantibodies that is seen in pernicious anemia. One is type 1, prevent the binding of intrinsic factor and cobalamin. Type 2, that prevents binding of intrinsic factor vitamin B12 complex with ileal receptors. And type 3 is that targets parietal cells. So, because there is a lack of intrinsic factor, so there will be an impaired absorption of vitamin B12 in our body. And that will lead to vitamin B12 deficiency. Now, pernicious anemia is very common in adult. However, children can also acquire pernicious anemia. So there are two forms, the congenital pernicious anemia and juvenile pernicious anemia. In the congenital pernicious anemia, it is usually present around 2 years of age when vitamin B12 stores acquired in utero become depleted. So the vitamin B12 malabsorption due to a congenital arrest of intrinsic factor production or abnormality in intrinsic factor structure. So, unlike in the pernicious anemia of the adults, the stomach lining and secretion of hydrochloric acid are usually normal in congenital PA. So, hindi affected si hydrochloric secretion in the congenital PA. Now, the next one is the juvenile PA. This is an acquired disorder involving autoimmune mechanisms that is usually identified in the second decade of life. So mga children which is age 10, between 10 to 19 years of age. So the affected children show evidence of gastric atrophy, and this is also considered as the early form of adult PA. For the clinical findings, so one half of PA patients develop glossitis, sore tongue. So severe glossitis is very painful daw. It appears beefy red. Tongue becomes very smooth. And if there is a reappearance during therapy, it may indicate an inadequate treatment. So patient will have a complaint of weakness. So mga common na siya na mga symptoms of anemia. So fever is a feature of profound anemia. So the hallmark of the pernicious anemia is the patient may have a delicate lemon yellow color skin, which is caused by pallor and mild icterus and blotchy brownish pigmentation with patches of vitiligo that may appear. So here are the pictures. So ito yung glossitis. Meron siyang patches. So yan, glossitis, beefy red. Unlike the normal na dili kayo red. And this is the skin of the pernicious anemia patient. So yung nasa left, yun yung lemon yellow color na skin. And this is the vitiligo. Now in the nervous system findings, the pernicious anemia, meron ding occurrences of neurologic disturbances. So although less common na siya karon, however, sa mga patient na may neurologic disturbances, nag-experience sila ng paresthesias. So approximately 30% of patients with pernicious anemia has experienced paresthesia. So 7% have spinal involvement. So si vitamin B12 deficiency may cause myelin degeneration and peripheral nerve degeneration. So this is manifested through via paresthesia. So paresthesia is described as prickling, tingling, pins and needles sensation in the hands and feet. So spasticity is also seen in the severe cases of pernicious anemia. Defective lipid metabolism may cause myelin degeneration. This is because the enzyme methylmalonyl-CoA mutase cannot oxidize fatty acids in the absence of B12. So vitamin B12 deficiency may cause subacute combined degeneration. This is due to the fact that vitamin B12 helps in the maintenance of the myelin sheath of our brain. So if there is a vitamin B12 deficiency, so wala nang magme-maintain, and that will cause myelin degeneration. The psychiatric symptoms or megaloblastic madness may include hallucinations, maniacal outbursts, paranoia, and schizophrenia. For laboratory findings and correlations, sa special hematology test, ang tinitingnan natin is the RBC survival, haptoglobin, and methylalbumin. Sa RBC survival, decrease ang survival ni RBC is because of the destruction or the premature apoptosis of the megaloblast inside the bone marrow or intramarrow. Si haptoglobin naman is decreased. It's because of the hemolysis, the intravascular hemolysis. And methylalbumin is also increased. This is also associated with intravascular hemolysis. Cytogenetics, ang tinitingnan natin is abnormalities in the bone marrow cells. Sa chemistry naman, is ito yung mga parameters. So since pernicious anemia is a vitamin B12 deficiency, so expected that the serum B12 level is also decreased. So folate, serum folate is not affected, so na lang sa reduced or normal or elevated yung ano. So variable ang level ni folate. Serum iron is moderately increased. This is seen in the progressive stages of pernicious anemia. The plasma TIBC or total iron binding capacity is slightly reduced. The serum LD is increased. It's because of the hemolysis or intravascular hemolysis, as well as the urobilinogen unconjugated serum bilirubin is also increased due to hemolysis. Now for the humoral immunity test, ang makikita natin are mga autoantibodies of intrinsic factor, parietal cells, and thyroid. So under intrinsic factor antibodies, meron tayong tatlo. The blocking intrinsic factor antibodies, which binds with intrinsic factor and blocks its vitamin B12 binding site. So ginagawa ni blocking antibodies is that binablock niya yung binding site ni vitamin B12. So, hindi na makakabind si vitamin B12. So, wala nang absorption of vitamin B12. Binding intrinsic factor antibody type 1, this attaches to an antigenic site on intrinsic factor that is distant from the actual B12 binding site. So the binding site is not dependent on whether or not intrinsic factor is complex. So the thought of ang thought lang ni binding intrinsic factor antibody is that mababind siya kay intrinsic factor without affecting the binding of vitamin B12. So makakabind pa rin si vitamin B12. However, ang gina-affect na niya is the absorption of vitamin B12. So, nanay problem sa absorption of vitamin B12. So, there will be a deficiency in the vitamin B12. So, itong antibodies na intrinsic factor can be detected in the lab by radioimmunoassay techniques. So, for parietal cell antibodies, ma-detect siya by complement fixation or immunofluorescent techniques. Parietal cells intrinsic factor antibodies can be detected or differentiated by gel filtration techniques. Thyroid antibodies can be detected by complement fixation, immunofluorescence, and tanned red cell agglutination techniques. So what are the other causes of megaloblastosis? So other causes is very specific in the morphology of megaloblastosis or megaloblast. So there are three types. One is an acquired mutation in progenitor cells. 2 is an inherited mutation, and 3 is interference with DNA synthesis. So, itong number 3 is usually yun yung mga drug-induced na interference. Under acquired mutation, progenitor cells, the dysplastic erythroid cells in MDS have megaloblastoid features. So, makita natin sa dysplastic erythroid cells in MDS is meron siyang macrocytic erythrocytes, and then there will show delayed cytoplasmic and nuclear maturation, which is cytoplasmic bacterial formation, nuclear budding, delayed ng formation ito. Inherited mutation, so si CDA and acute erythroid leukemia. Under kay CDA1, makita natin kay CDA1 is there is an internuclear chromatin bridging of erythroid cells or binucleated forms. In CDA3, meron siyang giant multinucleated erythroblast in the CDA3. Sa acute erythroid leukemia, makita natin and ma-observe is the macrocytic cells immature appearance of nuclear chromatin, which is same to the more open appearance of the chromatin and megaloblast. Ang i-remember na natin kay acute erythroid leukemia is there is an increased myoblast in the bone marrow. Under kay interference with DNA synthesis is the reverse transcriptase inhibitor. So ito yung drug which is used in the treatment of HIV. So si RT inhibitor may also interfere with DNA production, which may lead to megaloblastic changes. So, that's all. Thank you.